Hello, I'm going to give you a whistle-stop tour of our work looking at intramedullary cannulated screw fixation in the hand. Over the past few years, intramedullary fixation techniques have become increasingly popular for managing metacarpal and phalangeal fractures for many of the reasons listed here, but are not yet standard practice and are surrounded by some controversy. In this multi-centre audit at 2 tertiary plastic surgery centres, we aimed to assess functional ranges of motion, patient-reported outcomes and complication rates, as well as sample demographics and differences between centres in patients with metacarpal and phalangeal fractures managed with this technique. All patients with metacarpal and/or phalangeal fractures managed with intramedullary cannulated screw fixation over a 27-month period were retrospectively reviewed. Data were extracted from hospital notes. If ranges of motion weren't recorded in the notes at final follow-up, they were measured digitally from recent photographs. The Quick Dash questionnaire was administered by telephone and was chosen as it's validated and fast to use. Ranges of motion were recorded as total active motion, and outcomes were available for 34 of the 58 fractures. As you can see, metacarpal fractures had an average of 237.7 degrees at final follow-up, and phalangeal fractures had an average of 234.5 degrees. These are good and comparable to previous studies. Quick Dash scores were obtained for 34 of the 49 patients. Quick Dash is scored on a scale of 0 to 100, where the lower the score the better. As a benchmark, the mean of the US general population is 10.9, so the means here, metacarpal of 8.23 and phalangeal of 5.13, are good. In terms of complications, major and minor classifications were as follows. One major complication occurred, an implant breakage post-surgery. A new screw was subsequently reinserted with no further intervention required. And one minor complication occurred. A secondary tenolysis was scheduled in order to improve one patient's range of motion. Thus, the overall complication rate across the 58 fractures was 3.45%. Our findings are similar to previous studies, showing this technique is capable of providing good ranges of motion and patient-reported outcomes with a good safety profile. Of note, the comminuted and oblique fractures in our series had good outcomes, which is interesting as many consider these to be contraindicated. Students' t-tests showed that Centre 2 had improved outcomes compared to Centre 1, which we think is likely due to the increased frequency of wide-awake local anaesthesia no tourniquet at this centre, as well as a more vigorous early motion physiotherapy regime. Ultimately, this corroborates previous studies and further demonstrates the versatility of this technique, but prospective comparative randomised studies are needed to compare this to other methods of fixation, or indeed to no fixation at all.